So, Allie, what do we need to begin this concept of accessing a tooth? What kinds of things need to be in place for us to start having a comfort, have a sense that we're ready to start the process?
So that's a great question. So there are two separate things that we need to keep in mind. There is the things that we need to do pre-access, before we even start to access the tooth.
Oh, okay.
There are things that philosophically and conceptually we have to have in mind. And then there is the typical armamentarium that you need to do the access preparation. So let's talk a little bit about the pre-access stuff.
Perfect.
And the first thing, which we discussed also in our diagnosis course, is proper diagnosis. It's really critical that you have a pulpal and a periapical diagnosis before you actually set a burr to the tooth. You never want to be in a situation in which you are having a little bit of doubt about whether this tooth requires endo or not. You need to really know what's going on, and you need to have a diagnosis, not just for the medical legal reasons, but also because of the fact that, clearly you don't want to do a root canal on a tooth because it's an irreversible process. You don't want to do anything irreversible unless you have a diagnosis present. So that's obviously a logical thing, because a diagnosis will also help you, as we will talk about later on, with your treatment planning for emergencies, for example. Now, the other one is a proper anesthesia. And what I mean by that is proper pulpal anesthesia. Oftentimes people confuse anesthesia as just this one broad term. The way I explain it is anesthesia is like a ladder with different rungs. And while you could do many restorative procedures, amalgams, composites, crowns, these kinds of things, periodontic surgery, with lower levels of anesthesia, doing endodontic therapy that requires actual insult directly to the myelinated nerve fibers of the that basically innervate the tooth, requires the highest level of anesthesia. In fact, doing endodontic therapy in a irreversibly inflamed pulp requires the highest level of anesthesia in all of dentistry. So you need to make sure that you give adequate volume in the right place. And the best thing to do would be, I never ask the patient if they're numb, because they don't know the difference between tissue anesthesia and pulpal anesthesia. The best way would be to test the tooth using endo ice or using your electric pulp tester.
Yeah, really important issue. Really important point, because so many times, as being used to doing restorative procedures, we just ask the question, do you feel numb?
Do you feel numb? But that's not enough.
Going to work.
That's
for
not.
Endodontics, because the
Absolutely.
first thing you do is you wind up hurting the patient, and then they lose confidence. It starts a downward spiral.
That's a bad situation to be in, certainly.
Yeah.
So you definitely want to do your pulpal anesthesia test before you get started.
And that test is putting
endo ice or ethyl chloride, whatever you have, something to stimulate. Basically, what we always tell is to duplicate the diagnostic tests that you did on the tooth to find out if it's viable or not. And also, isolation, obviously, is a very important thing. Rubber dam isolation is the standard of care for doing your access preparation. Now, having said that, I also understand that some of the cases, due to their angulation and due to their the level of calcification, you need to modify your isolation. Right? So normally we just place the rubber dam clamp on the same tooth we're doing a root canal, isolate a single tooth, and do the root canal. The isolation for the access preparation on an easy tooth could be like that. But if you're having something a little more difficult with calcification, it would be best to put the clamp on the tooth behind it or two teeth behind it and isolate a number of teeth, maybe two teeth forward and backwards, so that you can have a sense of alignment, understand what is going on with all the adjacent teeth, so that you can align your access preparation better. That will certainly help you with the access preparation. Sure. In rare situation, when I have a maxillary tooth or something like this, it's severely calcified, and I can actually transilluminate through the buccal plate so you can see a little bit better. I may actually do the access preparation portion without a rubber dam. Now, that is not something that is recommended routinely, but only in really difficult calcified cases to improve the visualization. That may be possible.
And a split dam really,
But a split dam really is the way to do it, not really having no rubber dam.
I agree.
But if you do get to a situation where you have this calcification and you're doing it without a rubber dam, then as soon as you nick the pulp and you're in there, then you put the rubber dam on right away and you get started. Because the whole key there is to have proper isolation for your root canal therapy. Now, the other thing that is obviously common sense is good visualization. And good visualization is only possible through magnification and illumination. Now, as an endodontist, to me, the microscope is the way to go. In fact, I was telling some of the residents that if I had to do a root canal now without without my microscope, I probably couldn't do it. I mean, you just get so used to that higher standard of visualization. But for most people, it's practical that they can't have a microscope to various reasons. At that point, we at Real Dental, we recommend that people have 3.5x loops or higher in combination with light. That's really a key thing, to have the light to help with the visual, because as you go higher in magnification, you lose light. So as a result, you need to have the additional light. And 3.5, not 2.5. 2.5 is what most people use for restorative. You need to have 3.5 and higher. Actually, I probably prefer 4 to 5. So, and last but not least is good quality radiographs. And that cannot be underestimated, because, most people take just one little periapical and they're ready to go. Yeah. But you need to have, not only for access, but also for diagnosis, you need to have basically 3 x-rays to start with. You have straight on, an angled shot, which is about 12 to 15 degrees angulated, either mesially or distally. And then last but not least is the bite wing. The bite wing is really critical for your access preparation. It gives you a much better sense of orientation. As you can see in this radiograph, when you take a periapical radiograph, you can potentially, foreshorten the root. Especially if you have a crown, the crown margin will end up transposed over the roots, and you just lose all sense of direction and orientation. When you take a bite wing of that same tooth, you can see that you can actually see the floor of the chamber, despite the fact that there is a crown present. And usually with a bite wing, in today's world, using digital radiography, you can use the ruler in your digital radiography to measure the length of the crown to the floor of the furcation, and then kind of transpose that and make a little mark on that on your burr, on your access burr, so that you know how far you're in. And if you are reaching that point and you haven't found the canal yet, that's the point to stop immediately. And then you take another bite wing radiograph.
There's the one thing you cannot be afraid of, and that's taking an x-ray.
Yeah.
We tend to sometimes be overly concerned about taking too many x-rays and the patient's perception of that. But in endodontics, the best thing that you possibly can do, if you're not sure where you're going or what you're doing, is stop and take another radiograph.
X-ray is information, and the more information you have, the better off you are in terms of making the right decisions.
Sure. So what are some of the basic instruments that you need to begin this process of access? What would you recommend?
So during the access preparation, what do we need? So what we basically need during the access preparation is clearly a power source. You need to have your high-speed and low-speed handpiece, as well as a handpiece for your endo speed, if you will. Your rotary instruments, which would be your burrs, high speed and low speed. You're going to need an ultrasonic, and that's a key thing I want to just mention. Hand instruments, as well as an orifice opener, in order to finish that last part, which is getting direct access to the coronal 1/3 to 1/2 of the root.
Fundamentally, endodontics is as much as any other procedure that I know of in dentistry, is one of those things that you need to be prepared.
Yeah.
Because you don't want to be going to look for something that you needed after the fact.
Absolutely.
And particularly given the patient's circumstance of being involved in that kind of procedure. So I think armamentarium is something really important. Can you go over that a little bit in terms of?
Absolutely. Let's get into more detail on each piece. And I agree with you. You got to be fast. You got a patient with a rubber dam on. Yeah. You got the clock ticking because you got pulpal anesthesia that's wearing off by the minute. Right. So you got to get in there and do things fast. And preparation is the real key. And to that effect, having the right armamentarium that's reliable and it allows you to get to the results efficiently is really key. So
and available, not in a drawer. Not in a drawer.
That's the key to efficiency. Your assistant should never get up and go get something. Right. Everything should be right there. Right. So let's talk about the power source. On the high-speed side, you want to have a high speed that runs anywhere from 200 to a couple 100,000 RPM is basically the ideal thing that you want to have as a minimum. But the key here is torque. And when it comes to torque, there's nothing that can replace electric handpieces. So the low speed, which would be anywhere from 20 to 40,000, as well as the endo speed, which is before your orifice opener, that runs anywhere from 300 to 1,000 RPM. Those are the power devices that you're going to need. I use in my operatory, I use the ELM, the Forza unit by Brasler. I've had it now for the past 10 years. It's great. I haven't had to do anything to it. It's just been, I've used it on every case for the high speed and the low speed. The torque that comes out of that thing is incredible.
Yeah.
So I have two of these things mounted in my ASI cart. So it's both, I have a high speed and a low speed electric. As an endodontist, I need that nowadays because I need to have the torque to get in through these crowns that are fabricated in today's world that are basically my biggest menace to get through this lithium disilicate inlays, onlays on crowns and to the zirconia stuff and some of these old non-noble metals that come from overseas that are basically like kryptonite. I mean, I can't get through this stuff.
Do you ever get the sense that maybe the restorative dentist prepared that crown just to see whether you could get through it?
I know. I think sometimes we're just not even a part of that equation of thinking. That's part of the problem. I wish they thought about us too.
Right.
That sometimes you need to do endo through these things. But it's funny because at the school, so I teach at the postdoc endo program at the Harvard, and they have pneumatic handpieces.
Oh yeah.
And I was trying to help one of the students the other day. I just couldn't get through.
Couldn't get through. Sure.
How can you use a pneumatic handpiece to get through a lithium disilicate inlay? It's like 3 or 4 millimeters worth of material.
That's a 10 or 15. That could be a 10-minute job.
Sure, definitely. Yeah, it is. It definitely is. So that's for the high speed and low speed, and whatever electric system you use, just make sure that you use electric system as opposed to the to pneumatic.
How about the handpiece for endo?
The handpiece for endo, I use the EndoSequence 2 handpiece. It's a cordless handpiece. It's a part of the whole ESX EndoSequence system. Okay. So it's very easy to use. It's reliable. You have the cordless part of it is really great because we can move it from operatory to operatory. And I actually have a multiple number of these handpieces that I put in all the files in, so I don't have to change files. So that improves my efficiency, especially for emergencies, quite a bit because I can just quickly get in there and do a round of instrumentation without waiting.
Let's talk, you're an endodontist. I'm an endodontist, and I can certainly understand having a group of your files already set up in your portable handpieces. For the average guy who's doing a couple root canals a week, I would suggest that maybe if they were to think in terms of maybe having a second handpiece, that their assistant can be loading. When they are actually using a handpiece with an instrument in it, let's say a size 25, and the next instrument is going to be a 30.
I agree.
She can be putting the 30 into that handpiece. So generally speaking, if you have two of them, you're really in great shape. And also, God forbid, something forever not to work with one that I've never had that seen that actually happen that I remember. These are rechargeable, so if somebody forgot to charge one or something like that, you'd always have another one that was ready to go. But 2 seems to be an ideal.
I agree. I think 2 is the minimum, and then you can build from there based on the number of files and how efficient you want to be. That will certainly increase your efficiency going from 1 to 2. Okay. But let's talk about now the actual burrs and things that go into these handpieces. In terms of the high speed, now everybody has their own preferences. I'm sure you have yours. I have mine. Everybody has theirs. But I think systematizing it and finding out how we can get into a system of using the least number of burrs to cover the most number of cases is the way to go. I've found over my 20 years of experience a number of burrs that we actually have put together in form of a kit that is the Reworld Endo's Access Kit, and it contains about 8 burrs. And what I find in my endodontic practice is that with these 8 burrs, I can pretty much do 99% of my cases. There's very occasionally may need a specialty burr or something like that to get to the access. But that's basically all we need. And at the cornerstone of this whole thing is this one burr, which is a SaberCut 1557 or 58 is the one that is my bread and butter for my outline form. Now, I know a lot of people use like round burrs to get through for the access. I think that's It's certainly possible. You can use a Black & Decker drill to get through. The question here is how can you increase your safety and control over the head of the handpiece? And I think a round burr at high speed doesn't give you enough control. It's very dangerous, increases your chances of perforation, and so on. So having a burr that has also a little bit of side cutting while having an end cutting, it's not only more efficient, but it also gives you a little bit of directional control so that you can visualize a little bit better as you go deeper into the tooth.
The other issue is that a round burr tends to gouge the walls.
Yes.
And this does not. This tends to give you a nice straight line.
And that's what you want, a straight line. Remember, the
Right.
key here is a flow from the cable surface area of the axis all the way to the orifice so that the file can just slide in. So let's go over these 8 burrs very quickly so
Sure.
people can be familiar with them. The first one is the 5909, which is a flat diamond disc, if you will. And the reason I do that, I use that, is because I want to always flatten and adjust the occlusion before I get started on my preparation. My assistant has the patient bite on a very thick articulating paper, so I have the occlusal marks already. I like to flatten the cusps. If a tooth is going to get a crown, I'd like to flatten the cusp. If it doesn't, if it's not going to get a crown, or if it already has a crown on it, then obviously I'm going to skip this step. But if I'm going to have a crown, I flatten the cusp, and what that does is it allows me to have solid reference points that are perpendicular. Take the tooth out of occlusion, your patient's going to have a lot less pain post-operatively. That is a key thing. And it just improves my overall visualization as well.
Sure.
I take it off by about 1 millimeter or 2, which is going to be basically the depth of the crown reduction anyway. Then the next 2 burrs are these 2 saber cut burrs, the 1557 and the 1558. The 57 is a thinner version of the 58. 58 is the one that I use most of the time because as an endodontist, I'm doing mostly molars. Mm-hmm. So that's my bread and butter. But then the 57 is also great for anterior teeth, some premolars, and also if I have a tooth that has been prepped already for a crown and I need to make a conservative access preparation, then I would use the 57 instead of the 58. Now, this next burr here, the 6801 DC, which is the DuraCut burr. Now, this thing has been a lifesaver for me because the DuraCut burr has been the burr that has allowed me to survive the nightmare of the modern crowns. Yeah. So the modern crowns, as everybody knows, it's just incredibly difficult to access through because of the hardness of the surface. So especially kind of a glazed diamond allows me to get through these predictably and a little bit more efficiently. Granted, nowadays when I see a porcelain crown, I throw my hat in the air because I'm just happy to see it. That I have to go through porcelain and not through lithium disilicate, but that number is reducing by the hour. So I think it's a must. You have to have a 6801 DuraCut in your kit if you're doing any kind of an access through these crowns. The next 2 burrs are basically these utility, H269GK, and then the DuraCut version of almost the same kind of a configuration. And these 2 burrs help me at the end of the preparation to kind of, again, make everything, the outline flow right into the access opening. So these burrs with the round tip and a longer taper allow to provide a nice taper to my preparation. Now, the DuraCut version is for doing that when you're going through crowns that are lithium disilicate or zirconia. And last but not least, the tried and true number 2 and number 4 surgical length round burrs on a right angle, so on a slow speed. And these 2 are the ones that I use to remove the dentinal shelf, which we're going to discuss, any bulges or any things that cover calcifications that cover the orifices in conjunction with my ultrasonics, which is the other thing we're going to discuss. So that brings us to ultrasonics.
Yep.
Now, ultrasonics, I think, have been the one instrument over the past 15 years that has really impacted my clinical practice the most. I use them on every case pretty much all the time. Mm-hmm. If I had to choose between my ultrasonic and my apex locator on any given case, I would take the ultrasonic and not the apex. Yeah, I mean, you need it. You need it for access, for parts of the treatment, depending on what kind of treatment you're doing, and you're going to need it for irrigation, which is really the key thing, and debris removal, which is the other part of a thing we're going to talk about later on during this course when we talk about irrigation and its effects. So anyway.
What do you use?
I use the Forza V3, which is the Brasler unit. There's a lot of ultrasonics out there on the market. I like this unit because it has an LED light. It's really powerful. It has 3 specific settings. You got the general setting. So they have like 80 some tips on there. So you could use this for general dentistry. You can, do some refinement of your margins, remove some filling materials and so on with this. There's just enough tips to do everything with it. Then there is a perio setting on it where you can do your scaling and root planing.
Yeah.
And
it's very, very, very versatile.
Very versatile.
You're not just getting it for endodontics. This ultrasonic can serve lots of purposes
exactly.
in practice.
And for endo, it's quite powerful, which is really the key of what I want. So I can basically blow out posts and all kinds of difficult obstacles on my way, and it hooks onto your unit, and you can actually plug it in so you can get the unit water from your unit, and you can use it for debridement. And I think people who are going to use this for the access preparation and is using general dentistry are going to integrate it into their cards for general dentistry.
Oh, yeah.
Because anytime you remove an old amalgam, you got a smear of stuff all over the place. And then you use the air water, it doesn't come off. This is the best way to get rid of that stuff.
Yeah.
So let's talk about tips that are used for it.
Sure.
I have, there's about 5 tips that are used most commonly along with this instrument. And those are in a little kit with the endosequence. But that's pretty much, these are really the tips that you need for non-surgical use. Obviously, there's a bunch of surgical tips as well. But here, for your non-surgical access needs, your E4, E9, E9D, E14D, and E15D are basically the ones that you need. The E14D is the one that I have on there pretty much all the time. And then I would change it to maybe an E15D if I have some calcifications or something like that I'm looking for. And E9D for refinement.
You know what I think, in my mind, the one aspect of this which is sometimes forgotten is that in very, very calcified cases, there's nothing better than an ultrasonic to find a canal, to find a MB2, as an example. And it takes a little bit of acknowledgement that when you take a burr into a root, into a space that you cannot see because the head of the burr actually takes over, and you can't when you go by feel.
Yeah.
With an ultrasonic, particularly one with an LED light, you actually can visualize,
for the first time, see what you're doing.
See for the first time.
It's not a do and guess and see what you did.
Yeah, fabulous for finding
no question
canals.
about it. Yeah, it's so many different uses for
Tracing
ultrasonic.
the end of
Everybody should have an ultrasonic, basically.
If you're doing root canal therapy, I think it's really a must.
Absolutely. Yeah. So for hand instruments are the next things that are also used. And, there's not a whole lot of hand instruments you would be using during access preparation. Pretty much your Explorer, which is DG16. Some people have it's kind of a 17 head on the other end of it. These 2 instruments by Brasler, the DG16 and 17 on the 2 ends. And then the surgical curettes are really the only things that you need. Use the 17 head to find out if you have a remaining roof of the pulp chamber. The DG16 end is used to explore for canals. But to be honest, Dennis, I'm not using the DG16 as much anymore. I'm using the ultrasonic tip is kind of enough. I could see the tip basically finding the canal for me as well, plus the visualization with the microscope. But for people who don't have a scope, I guess you got to still use the DG16 as your tried and true way. And the spoon to remove decay and remove any, a sharp curette like that, if you will, to remove the pulp tissue if you're doing pulpotomy possibly. Yeah. So those are really important things.
And the reason why we're kind of going through these things is because we really want everybody to have a sense of what they need.
Yeah.
These are the things that you need if you're going to be doing root canal therapy.
No, absolutely.
So we don't want to be belaboring the whole process, but it's really important to have the right things when you begin this process.
Absolutely. So and last but not least is the orifice opener. So now these are all the stuff that we talked about allow you to get to the orifice, but remember that our definition of access is access to the coronal 1/3 to 1/2 of the root. Therefore, you need to have a couple of instruments with the endo handpiece in order to help you kind of provide that. And for that, we're talking about maybe using orifice openers. Some people prefer to use Gates Gliddens. Those are great too. I used to use Gates Gliddens, but then orifice openers came along, and it's just basically putting 3 or 4 Gates Gliddens onto one instrument, and that makes an orifice opener.
Exactly.
So it's a lot more efficient to use an orifice opener rather than a Gates Glidden, and it doesn't give you that parallel look. And gives you a better taper. And for that, I use this system, part of the ESX, which we discussed in our instrumentation video. But the orifice opener, which is a size 20-08, the tip allows you to go in, and the 08 taper allows you to get a little bit of opening, because you need to have that coronal opening in the coronal 1/3 to 1/2 of the root in order to be able to explore and get down to the apex better. And there's a couple of these ControlFlex files that they have also in the system that are stiff. And these things are really good, because right at the beginning, what you want to do is you want to go in there and find the the available length that you have, then use your orifice opener to just open up that space. Now you've pretty much opened up to the mid-root part. Now you begin your instrumentation, which we cover in the instrumentation portion.
And there's kind of a fallacy that all hand instruments are the same.
No,
it's really not true. And if you use a instrument that's a little stiffer and has the ability to feel, it doesn't bend away from you, but you can feel. That's how you really can locate and find things.
You don't want your files to buckle every time you put a little bit of apical pressure on them. That's really key, and you need to have smaller files in order to get through. So this is the way of combining the two. And lastly, Dennis, there's this one file, the 1505, which is a part of the ESX system, that is the expediter file, that is also handy. Now, this is a little bit of a cheating thing, because it's part of the instrumentation really at this point, but if you just do 1 or 2 SSC strokes, which is single clean and single stroke and clean strokes, which we discuss in our instrumentation video, it will help you get a little bit of mid-root opening that will go a long way in terms of your ability to then go back with hand instruments and negotiate the apical 1/2 of the root before then you begin to instrument it. So I think this is the addition of this expediter file to the Access is a helpful thing, because it does just 1 or 2 strokes there can give you a little bit of a mid-root opening. And now at this point you have straight line access to the apical 1/2 of the root, and you're ready to go. So let's come back and talk about the access for all of the teeth in the mouth, if you will, one by one, and their outline form.